Jerusalem Guidelines for Acute Appendicitis, the 2015 Consensus. Hey everyone, welcome back to the channel. Today we're diving into something super important for anyone interested in medicine, emergency care, or just curious about how doctors make decisions. Acute appendicitis and how it's handled around the world. Specifically, we're talking about the Jerusalem Guidelines from 2015, which brought together experts from everywhere to agree on best practices. Let's break it down. 1. What are the Jerusalem Guidelines? So first up, what are these guidelines all about? In a nutshell, they're a set of recommendations created after tons of research and expert debate. The goal? To help doctors everywhere figure out the best way to diagnose and treat acute appendicitis. No matter if you're in a big city hospital or a rural clinic, the big idea is to use risk-based strategies to get the best outcomes and avoid unnecessary treatments too. How do you diagnose appendicitis? Alright, let's talk about diagnosis. If a patient walks in and you suspect appendicitis, what should you look for? History. Classic symptoms are pain that starts around the belly button and moves to the lower right side, a loss of appetite, which actually happens in more than 90% of cases, and nausea or vomiting that usually starts after the pain. Physical exam. There are some famous signs, like tenderness at McBurney's point, rebound tenderness, and those special moves, Robsing, psoas, and obturator signs. If it's not clear, sometimes a digital rectal exam can help. Scoring systems. Ever heard of the Alvarado score? It's widely used to assess the likelihood of appendicitis. It takes into account things like pain, migration, anorexia, nausea, RLQ tenderness, rebound, fever, high white blood cells, and a left shift. The score can be low, 1-4, intermediate, 5-6, or high, 7-10. There's also the AIR score, which is great for ruling out appendicitis if you score 4 or below. Imaging. For adults, the go-to is a CT with IV contrast. Super accurate, but you can use a low-dose version to cut down on radiation. If someone's got kidney issues, go non-contrast. For kids, ultrasound is first line, pretty accurate, and you only jump to a CT if things are unclear. For pregnant patients, ultrasound comes first, and MRI is safe, without contrast, if the ultrasound doesn't show much. And for women of childbearing age, always start with an ultrasound to check for gynecological causes, then maybe a CT if needed. 3. How do we classify appendicitis? Alright, now that you know how to spot appendicitis, let's talk about how doctors sort it out. Uncomplicated. It's contained in the appendix. No signs of rupture or abscess, and white blood cells are a bit elevated, 10,000 to 18,000. Complicated. Now we're talking about perforation, an abscess, an inflammatory mass, phlegmon, or widespread infection, peritonitis. White blood cell counts are usually even higher. 4. What's the best way to treat it? Let's get into management strategies. Uncomplicated cases. Laparoscopic appendectomy is the gold standard. It means fewer infections, shorter hospital stays, and faster recovery. But if someone has had lots of previous abdominal surgeries or is late in pregnancy, an open approach might be better. Ideally, surgery should happen within 24 hours of diagnosis. But here's an interesting twist. There's also an antibiotics first approach for select patients, early stage, no fecal if, and WBC under 18,000. They start with IV antibiotics, then switch to oral, and about 70 to 80% do well for at least a year. It's a shared decision between patient and doctor. Complicated cases. For an abscess bigger than 3 centimeters, doctors may do percutaneous drainage plus IV antibiotics. Once the infection calms down, many patients have a delayed interval appendectomy about 6-8 weeks later, though in some older or high-risk patients, they might skip it. But if there's widespread peritonitis, it's emergency surgery, often with a midline incision and a thorough washout of the abdominal cavity. 5. What about antibiotics? For uncomplicated cases, a single pre-op dose is usually enough, commonly cefazolin with metronidazole. There are a few alternatives too. For complicated cases, you'll see stronger regimens like piperacillin tazobactam, or ceftriaxone plus metronidazole, or even ertapenem. The treatment usually lasts 5 to 7 days after the infection source is controlled. 6. Anything special for kids, pregnant people, or seniors? Pediatrics. Kids have higher rates of perforation, up to 45%, and ultrasounds can be less accurate in obese children. Post-op abscess rates are also higher. Pregnancy. Laparoscopy is safe in the first trimester, but in the second and third, open surgery is often safer. MRI is okay if you skip gadolinium. Seniors, they tend to have unusual symptoms, much higher perforation rates, and a higher risk of death compared to younger adults. 7. Quality markers. How do we know we're doing a good job? Give antibiotics within an hour for septic patients. Keep the negative appendectomy rate below 5%. Laparoscopic surgery in over 80% of cases. Fewer than 5% surgical site infection rate. 8. Hot topics and what's coming next. There's still debate about using antibiotics first for uncomplicated cases. It's not settled. And there's exciting work on new biomarkers like IL-6 and procalcitonin that could make diagnosis even better. So that's the scoop on the Jerusalem guidelines for appendicitis. Thanks for tuning in. We hope this episode helped break it down. Don't forget to like, subscribe, and share for more surgical deep dives. It's the Everything Surgery Podcast. Dissect the extraordinary.